that's really required, which is in this pre-maxillary area. Now, if I ask people, what are the methods that A point can come forward? Can anyone go through that? So our goal in a 3A is to drive A point forward. Right? There's 5 ways A point can come forward. Paula, can you give me one way A point can come forward? Good, yep. Hilary, another way you can drive A point forward. Just in general terms. So I'm not after the name of an appliance, I'm just talking about in general principles. Well, a face mask, so she's answered that. I'll give you a tip, you're looking at it here. As you expand, yeah, expansion drives premaxilla forward, do you understand? Particularly if premaxilla is still growing, meaning young kid. Yeah, Shiraz, another method, 2 out of 5 have been taken of driving A point forward. Think about why I use low torque brackets, Shiraz,
By bringing the roots.
Exactly, and what's the correct term for that? Negative torque. Does everyone understand that? If you use light force as a negative torque, as the root comes forward, the bone comes forward, right? Yasmin, 4 out of 5. I'll give you a tip. In this country, there's not very good people to do it. How about a Lefort 1? Will that bring A point forward? I think so. Come on, I know it's early in the morning, yeah? Okay, now, my friend. Oh, that was your answer, yeah. Okay, I'll give you a tip. It's probably a little bit difficult. You could say sagittal appliance, couldn't you? Provided you have a growing child, so I'll take that as an answer, but I wouldn't put that in my top 5. The other one is Frankel's research, what's called mucoperiosteal slippage, the Frankel effect. I'll talk about this tomorrow in retention. When you make a Frankel, you muscle trim it because the acrylic needs to be putting pressure on the mucoperiosteum. And that pressure causes bone to have apposition. Does that make sense? All right, so we'll go through it again. Light forces stimulating, and from people who did my Damon course, what's it called? Not undermining resorption, frontal resorption. Yeah? Use of appliances that are driving forward, surgery, and face masks. And if you want to be really accurate, face mask with expansion is going to give you the best A point coming forward, right? So that's why when I'm doing 3A cases, I'm expanding, I'm face masking, and I'm using low torque, yeah? Then I'm retaining in the Frankel. Can you see it? 4 out of the 5, I'm helping. This is what I'm trying to get you to think about, all right? When you have a super screw, when you have a spider screw, when you have a jack screw, it's just a little screw. It's the way the technician puts it in the appliance that makes the difference, you understand? So any of the screws can have occlusal coverage, right? Any of the screws can be molded to a framework that has a face pad. Does that make sense to you? I think what you guys are thinking is somewhere in a factory in Italy, there's a spider gear that comes with a face mask or what? No, it's a little screw.
It can be modified to have occlusal coverage.
Exactly. I'll show you how, Godino. And you're going to see a case in a minute, right? What would happen is the framework, right, that they solder on, you could have this gear. Now this gear is currently soldered to that molar band. Do you understand? That gear can also be soldered to a framework for your high racks. You understand that? Yeah. So please, one good thing for you, next time you're at one of these big trade meetings, IDS in Cologne or something like that, go and have a look at the companies, that are selling the screws, not the finished product. It makes a lot more sense. Yeah? And one thing I'll tell you about jack screws, right? 70 to 80% of jack screws come out of Germany. Dentorum, Forestadent. Yep. Why? Because in Pforzheim, in that area, they had the precision stuff during the war for the timings of the bombs, etc. They will tell you themselves that jack screw has a high tendency to slip back. Who would agree with that? Yeah. But they're making for a budget. Does that make sense? Right? So, if you buy a bag from Louis Vuitton, you don't want the bloody stitches to fall apart in a few weeks, unless you bought it in Singapore on one of those street stalls, the Louis Vuitton outdoor markets. That's where I buy all my LV. Yeah? You understand? However, if you go to, I don't know, what's a dodgy brand in your country? The shop, I guess, or something like that. Yeah. You know, you're paying for something, and you know, if you get a few weeks out of it, you're happy because that's what you pay for. Welcome to the world of manufacture. Yeah. So those screws, who's had the old jack screws that turn back after a while? Who's had the jack screws that don't work, even when the patient is turning them? You know, the company itself will admit that to you, right? But they also have the upper quality thing. Now, the super screw, trust me, I've done, I'm not kidding, at least 9,000 super screws. I think I've had 2 that were faulty, right? And here's a tip for you. Get your technician, when they're doing the super screw, and all technicians should do this, right? Before they manufacture, they should turn it to a maximum and turn it back. Do you understand? Right? That way you check that the gear's working fine. Just like, you know, those closing core springs, what did I say? Before you use them, you need to pre-activate, preload, yeah? So the thing that we want to do is, if you have a maxilla that is insufficient, okay, in width anteriorly and retrognathic, you would use a bonded Hyrax, do you understand? But what's your Hyrax going to be? The super screw. So do you understand when I use the term bonded Hyrax? It can be any damn screw you like. A minute ago I had a slide showing 2 bonded Hyraxes with frameworks. One had a jack screw, one had a super screw. Nothing wrong with then having a spider screw. How does that sound? So the term Hyrax is not the screw. We went through this in course 1. The term RME is not a screw. So it's ridiculous when someone gives me an appliance and said, this is an RME. I'd say, well, hang on a minute. It's only an RME if you turn it the wrong way. Do you understand? So what's the correct term for our fixed expanders? Fixed Hyraxes. Bonded Hyrax, banded Hyrax. But the screw can be anything you choose. Right, Dino? Okay. So, in this girl's case, her Shorts Corkhouse is narrow here. Yep. There's the gear opened up. Can everyone see how that V was together and now it's open? And look at that nice arch form. Now, one criticism I have of the bonded Hyrax is what? You end up with a very square arch form after the expansion. Do you understand? But then you recover because your arch wires, your Damon arch wires, give you back that nice Roman arch. So here she is before treatment. She's kind of one of these edge-to-edge class 3s. Expansion beforehand. This is before the gear was opened up. There's the bite. Can everyone see in class 3s? I hope you're learning something. What do you see in that photo that you may not have known before this course? Look at the tongue, right? The tongue is working against you in a class 3. Read that article, the reference I gave you by Moyers, yeah, talking about the elevator effect of the tongue. What's your best expander, for Christ's sake, that has no screw and no lab fee? The tongue. Do you understand that? Yeah? So Ian, in place of an upper 3D, I prefer the tongue at a young kid, right? And it'll help you when you do the whatever. Unfortunately, there is a period of time when you're doing your expander, the tongue space is encroached upon, isn't it? Yeah? But as soon as that expander comes out, you've got to be all over that kid with tongue on the palate. So, you know, this needs to be up there. To help it, you do that. Now, again, let's talk about rate of expansion. Can everyone see that the suture is not split? If I was doing rapid expansion, yes, RME, either using a jack screw, a super screw, or a spider gear, it's the rate of expansion, then what would you see here at this stage? Black, wouldn't you? And what would the patient tell you? Oh, getting nosebleeds. Yeah? I don't know whether you've ever done an RME, but the patient hears the pop. I'm not kidding. It's really a horrific way to do expansion. That's the way we were taught, right? What you're seeing here is semi-rapid expansion, meaning, what is this? Can anyone give me the right name for that? Osteoid, new bone. Very good. Which means by the time you have taken the expander out, you're still retaining the expansion with your 2x4, your wires. That's remodeling. That's why expansion's stable. How does that sound? Okay? The slower you expand, the more stable the case. But there's a time limit where people just want to get on with it. So to me, kid, semi-rapid, adult, slow. never rapid. Go back to course 1 notes. I went through that. Read the John Mew article, American Journal of Orthodontics, where he reviews expansion rates. All good stuff. So here is the expansion now. Now, this kid really, even though the upper jaw is in a better width, is still needing the maxilla to come forward. Who would agree with that? Right? So the point we're trying to say here is that the width of the maxilla and the position of the maxilla are two different things. Doing one of these spider gears, definitely, if you look at where the kid started and where the kid is now, the width is much better, no doubt about that. But the AP hasn't really changed. When was the best time to put the face mask on? After a month of expansion, when the sutures were mobile. Does that make sense, right? So right now, say you say, oh shit, I forgot about the face mask. You're pretty stuffed, aren't you? Because that appliance is no good. You can't just sort of add a face mask hook on. This is what I'm trying to get at, right? So if in doubt in a 3A, and you may not think you need a face mask, right? Get the design with the pads on there. You can always cut them off. It's easier than trying to have to add them on later. So just kind of showing you the concept of the spider gear. Now, in this girl's case, certainly that little bit of early expansion at least gave her a positive bite, but had the spider gear been used with acrylic coverage and a face mask and then low torque 2x4, how much better would that result have been? Right? So expansion does help. The expansion on its own is only one of the 5 methods of getting a point forward. What would I like? 4 of the 5. You understanding where we're coming from? So largely we're getting dental changes. Now, what about a non-growing individual? What about a class 3A adult? Can we expand? We need to. Yeah? We can if we do it slowly. And there you could still have your bonded hyrax, but your turning would be a lot less, yeah? Or you could go for a Dave Singh DNA appliance. Sorry, what's he called his? Yeah, DNA appliance. A Ted Belfour Homeoblock, right? You can, this is where removables come in well. Adults are quite motivated. And if you say to them, listen, it's surgery, SAE, which I can do in 2 weeks, and you're done, or it's up to 1 year of you wearing a plate every night. Yeah? Now the adult will say, well, you know what, I'm busy at work, there's no way I can have 1 week off recovery, I haven't got private health insurance, so I can't go, so I said, fine, why don't we make you remove? Does that make sense? Now the other alternative is Damon. Do you understand? So this is an adult, and you would look at that and you'd say, yep, needs expansion, right? But if you understand self-ligation and you understand how to use the wires properly, the longer you use the 014, the better expansion. So in an adult, I might have that 014 in for 3 to 4 months. Yeah? So the question is, if my patient doesn't want surgery, but will accept braces, I'm Damonizing the arch. Happy? If my patient doesn't want surgery, doesn't want visible display, I'm going for an appliance at night with slow expansion. And that can be a Schwartz, right, in an adult. Now people are going to say, you can't use a bloody expander in an adult. How many times have you heard that? You can if you turn it slowly, because even when you're on your deathbed at 80, right, and you need an expansion, your sutures are still active. This is where the traditionalists don't understand. I was taught that at 14, for a boy, it's all over. For 12, for a girl. Who's heard that story? You can't do that. Why? They're talking about rapid expansion and splitting the suture. Slow expansion, you could. Now, here's a thing. The guy called Mark Pick wrote a textbook on expanding in adults. He basically photographed cadavers, pretty weird guy. He changed the zoning of his house into a morgue, and he spent a whole year doing slow time-lapse photography on expansion in non-growing individuals, showing that you can actually open the suture. And the slower he did it with, like, red kidney beans that you put in water and they slowly expand, He put appliances in there, So it is possible, there's no thing. But the average person would say, look, you've missed the boat for orthopedics. So to me, you can still do orthopedics in a non-growing individual, provided you do it slowly. Who would agree or disagree with that? Another good book for references. Dave Singh has written a textbook on epigenetics in orthodontics. I think, Rob, you can keep that. Well, I saw...
Not that particular one, but... we got the inlet one up there.
Right. Now, there is what we can do if you have light forces in a non-growing individual. Okay? So, here is a kid who's class 3, but CVM 5. CVM 5, class 3A. What can we do, what can't we do? Well, I think too old for face masks. Agree? Yeah? But we can still give her a normal bite by expanding the upper. Does that make sense? Can we bring her face forward? No, but if we do low torque in the upper slowly, we can get some 8 point forward, yes or no? We just can't use a face mask, yeah? What could we do if she wants to look perfect? Do our arch development and get our surgeon to do a maxillary advancement, yeah? What else could we do in theory? An ALF, I would try, right? So ALFs, like if I gave her the equivalent of a end sagittal, yes, with a middle loop as well, I'd have no problems with this girl having an end sagittal and Damon. And the end sagittal would give me 2 of the 5 8 points remodeling with Damon. Everyone happy with that? So I want you just to do your checklist, right? Here's the patient, we know 8 point needs to come forward, they're maxillary deficient, 3A. But their age, their, blah, 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 which of the 5 can I use? This is what I'm trying to get at. And don't just think you can only do one. In sagittal, which we will talk on ALF during these programs. Would work really well for this girl. And The whole concept here is because of the class 3, you would want to definitely not take teeth out in the upper jaw. And you'll learn this afternoon. You may take out one lower incisor in the lower jaw. Gets back to the tongue. Herth class 3, can you see where the tongue was? Yeah? When you see a nice arch like that, tongue's been sitting there. So, no face mask, but Damon brackets. With Damon, if you aren't going to use a light wire with it, right? You could do the Damon technique. I've given you all the Damon protocol book. Look at the section on cross elastics or crossbite. Damon. What Damon does, rather than go 014, 1425, $18.25, he goes 014, 14.25, and then he goes to his stainless steels or TMAs, right? And with that, he can get some good expansion with an offset bend. He can get some good torque. And he supplements it with cross elastics. So Damon's quite clever. Tubes on the buttons on the 6s with elastics, right? Now, as that happens, the elastics tend to do that to the molars, don't they? But Damon is already prepared by having a high negative torque molar tube. So any expansion case, you go for the minus 20. Molar tube. Do you understand that? Because you know this is going to happen, but when you get to those rectangular wires, that's going to happen. You actually get very good expansion. So make a note, anytime you use cross elastic, you need to have, you expect crown tipping and then the root needs to catch up. So you'll need to have negative torque, big time. So you can't just have one molar prescription, right? I on average use minus 10. But when I'm doing expansion, light wire, adult, go for the minus 28. The big time negative torque molar tube prescriptions. Or learn how to wire bend. When you get to that final wire, the 1925, with your tweed torquing pliers, you're going to put in some buckle root torque. Yep. These are all the options to recover. Okay, and just showing you, you can still get beautiful expansion in a non-growing individual. And you can get some 8-point remodeling. Remind me again, guys, what would be the 2 ways this non-growing female would get 8-point coming forward? With negative torque brackets and an end sagittal. How does that sound? Right? But please don't put a face mask on her, because you'll be caned mercilessly, and you know, I'll be the first one there to throw the first stone. Do you like that, Ian? Right? Because I live in a glass house, obviously. Look, it's all about understanding biology, and it's all about, so I'm very evidence-based, but at the same time, I know what I'm talking about. So I don't say, look, you can't expand in an adult, you crazy? Need surgery. So I will say to this girl, if you want a good-looking face, right, if you want to be perfect in balance, here's your arc, you're way behind there. If you want to be on the money, let my surgeon do a little procedure, and you need to see him anyway because your wisdom teeth are packed in, my love, yes? So what will happen, I'll make a surgical expander, bands on the 4s, bands on the 6s. I'll cement it the day before she has her surgery. The surgeon will take out her wisdom teeth, do a releasing corticotomy, yes? Got it? Then she'll wear a face mask. And guess what? It's like her being 9 again. How does that sound? And I do that a lot. And that's a lot less headache than a Lefort. A Lefort's a big operation, trust me. If you've never seen a Lefort being done, go chairside and watch one. It's not a pleasant experience. And a lot of post-operative pain and discomfort in healing, blah, blah, blah. But yes, it gives you the ultimate. But if a patient wears a face mask after surgical cystic expansion of the maxilla, didn't I show you? Yesterday? You get beautiful results. So can you see I'm giving you a number of options? So adults, 3A, too old for traditional. Face mask, CVM 5, 6. What can you do? Damon, Alf Damon, SAE face mask, right? Lefort. All of the above. So just offer patients choices. Okay, now, getting back to where we are in the program, I'm still covering arch development, and the take-home message is fixed expanders that you can incorporate face pads for your reversible face mask, and acrylic for sliding and correcting the crossbite. So you can use super screws, spider gears, etc. You've got to design the appliance. We then talked about rate of expansion. The younger the patient, the more you can go semi-rapid, but never rapid. The older the patient, the more you're going to have to slow things down. After I finish this last case, I'm going to then go into 3Bs, which we didn't really touch on. And of course, the ideal solution for a 3B is wait till mandibular growth is complete and then surgery, right? But if the mandibular growth hasn't been that excessive and the patient's not concerned by their face, you could still get a very good dental outcome using Damon braces with TADS. So I'm going to offer you the options of surgery, and one thing good about surgery, if you have a good surgeon, is the orthodontics is the easiest orthodontics you'll ever do, right? You don't have to worry about center lines, you don't have to worry about the class 3 crossbite. You basically, it's like having a typodont and just lining up the teeth on the jaw, yeah? And if you You do that, take some study models, the surgeon then puts the models together, make sure they articulate, and there's your orthodontics done. So to me, most general practitioners are scared of surgery because they've been told from the go-get by idiots who don't do surgery that that's a cop-out, and, you know, why that person have surgery? People need surgery, you know. There's no doubt about that. But a good surgeon that's traumatic can give you magnificent results that will make that patient a great referrer. My surgical patients are some of my best referrers, and they've gone through the most complex treatment plan, but I offer you non-surgical options. I just don't want you to talk the patient out of surgery, okay? Which a lot of my general practitioners do. Because they have no clue about surgery. I think it's the patient's decision. And I always give my patients the options. I make them meet with the surgeon. And then they come back to me and say, look, I've met with a surgeon, I've considered my options. I do not want surgery, bang, surgical waiver, away we go. Or they come back and say, look, yep, I definitely want to improve my facial aesthetics. So I need to know that before I put braces on. I can't put braces on and say, look, let's just start, and then you tell me how you're feeling mid-treatment, because my movement from day one is different. In a Class 3B surgical case, I'm starting Class 2 elastics from day one, right? In a Class 3B non-surgical, I'm staying in round wire in the lower. So there's lots of various options. Okay, little boy, early loss of deciduous canines, Class 3A, and we need to address the Class 3 pattern, the anterior crossbite, make room for the blocked out teeth, etc., etc. So, because there's arch length loss as well as underdeveloped maxilla, because there's a retrognathic maxilla, it's a McGill A with a face mask. Because he's low angle, I'm happy with a petite. So I'm just going through differential criteria while we're doing what we're doing. Then, initially, in phase 1, we're only going to do upper 2x4. Why? Because he's a 3A, he's a young kid, I'm going to wait till CVM 5 to 6 before I strap him up. Low torque brackets, make room for those cuspids, regain the arch length that's been started by the orthopedics. Then, phase 1 retention, wire to keep the teeth straight, Frankel to maintain the arch width, keep us in the zone. When he goes to his final growth, then straight wire. This is an old case, so I think I was still using twin brackets then, but normal rules apply. He's a low angle class 3, so his straight wire evolved class 3 elastics. Tomorrow it's pretty much all straight wire class 3, so you know you'll get a bit more of that. Retention will always be fixed retainers, but as a backup, particularly if I finished his ortho a bit earlier than final mandibular growth, maybe I'll give him an upper 3D, not as an active appliance, but as what I call an active retainer. Right? So we'll go through those options. Here he is sort of into phase 2, he's CVM5-ish, better profile when that maxilla's come forward, still the deep bite, so an intrusion arch being utilised here with twin brackets, but effectively the canine that had no room has now got space because of our orthopaedics. The crossbite was eliminated with some resin just to kick his incisors over. Once his incisors over, we could reduce that resin. And as you can see, initially there was zero space for the cuspid. Now there's room for the cuspid and the premolars coming through. And this is in the phase 1 situation where his hyrax has come out, but he still has some partial bracketing. Now, when I use the term 2x4, that's a generic term just to let you know I'm doing partial braces, but the correct term is partial braces. Now, if I go 3 to 3 or 2 to 2, it's still partial braces. That's the point I'm making. So I don't want you to get bogged down with this, oh my God, it's phase 1, but his canines are there. Do I bracket them on because isn't that against the law because they won't be 2x4? Don't give a rat's, yeah? I just want to maintain my expansion. Now, can you see the expansion? That is many months after the hyrax has come out. You got it? Right? And there's a bracket on an E. Is that the end of the world? No? You play it by ear. As long as you keep that arch form until he's ready for the full fix case. This is a good case, and there's a, I think Patrick McEwen, right? He's in Belfast, right? Galway, okay. So he's on his website talks a lot about phase 1 class 3 retainers, which is quite amazing for someone who's not a dentist, and he really got the nail on the head. So let me kind of share this here with you. This girl, also maxillary deficient class 3A. You can see from the face. Are you guys now sort of looking at faces and realising when someone's sort of flat? After a while, the face will give you the whole diagnosis. It already does for me. I only supplement it with the X-ray because sometimes the vertical throws you. But at the end of the day, if my face doesn't match what my tracing is, I really go back and do a second tracing or do it like a WITS, because it's the face that guides my treatment plan. So, this girl's had a John Mew sort of stage 1 BioBlock. BioBlock is a good appliance for a 3A because, believe it or not, a BioBlock acts like a Schwartz sagittal. Yes or no? Has anyone done BioBlocks here? Yeah. You know how John likes throwing those uppers forward? It's fantastic when they're 3A, really is. So if there's one indication, I've used a lot of BioBlocks in my life, but only stage 1. For a kid to wear stage 3 BioBlock, oh my God, you need a special kid, seriously. I think it's very, very cumbersome appliance, and it's removable and blah, blah, blah. But face mask, obviously, for the retrusive maxilla with a removable, okay? So it can be done, I'm not saying it can't, but here's the problem. What about now when we go to the fixed, do you see? If, say, this is your case, I quickly put this one up because of what you were asking, because I remember, the same situation. Now, if the incisors are not that crooked, go into a 1425 from day one. How does that sound? Low torque brackets here, yeah. Coil spring, like a degainer. Tubes on your 6s, vertical or not based on high angle or not. This goes overclosed, so you can put them gingival. And that will at least maintain what's going on. Now, what McEwen's saying here, once you've done your early class 3 correction, the most important part of retention is the tongue. And that's why I think he's a good guy to didn't he come here to chat one day when he was, was he good? Yeah, I've invited him to speak to Australia. I've flown him to Australia 2 occasions to speak to my study groups there, 2 3-day courses. I think he's fantastic. Okay, so what he's saying here is he's going into a, remember yesterday, what's this one called? IC3, yeah? Or you can use a Frankel, or you can use the YC3, it's totally up to you. But the point is, he starts a ton of breathing well / tongue thrust exercise. Now here's the thing. We all believe in myofunctional therapy, but even in that camp, there seems to be people who focus on the tongue and those who focus on the breathing. Do you understand? Those who focus on the breathing seem to think that if you breathe through your nose, your tongue will automatically elevate. Those who believe in the tongue believe that if you put your tongue on the palate, it'll fix the breathing, right? I really think you need to look at both things. So I work with a lot of ear, nose and throat guys for the breathing, but they're crap in then maintaining the lip seal. Does that make sense, right? In the same way, I work with a lot of people for tongue thrusts who have no idea on a narrow palate or the fact that you can't breathe through the nose. So you are driving the deal, right? So you should be working with an ear, nose and throat and a Buteyko practitioner. I have a device which is called a capnometer, and basically every new patient that comes in, part of the records, it takes 20 minutes to do, my nurse does it. They basically sit there, they have these little electrodes under their nose and it measures their breathing. It shows how much mouth breathing, how much, and it gives the parents an idea quantitatively of where we're going. And I say, look, if we want success in this, I'm going to expand your kids up the jaw. You're going to go and see an ear, nose and throat doctor, and ultimately our goal is to get your breathing up here. And when parents see it and the kid has something to aim for, it works really well, right? Now, these are not expensive machines, and I think that is your electronic Buteyko practitioner, if you want my opinion. Yeah? But Patrick has some very good exercises, so I'd recommend him. And he's actually been generous enough to put a lot on his website. Yeah? So, the concept, if you look at this girl's facial development, nice looking face now. See the sclera of the eye, see the cheek angle, all from that early expansion, that early sagittal. So where are we going with this? A McGill A is a fixed version of a BioBlock, because a BioBlock gives you expansion and AP, or a Schwartz sagittal. How are we going with that? You can use a Schwartz sagittal and a BioBlock with a face mask. No problems with that. I just feel though that unless you've got very good teeth for retention and good class, the thing is going to displace with 500 grams of force. Yeah. So to me, and of course, what's the biggest problem with a BioBlock and a Schwartz sagittal? Compliance. Yeah. Eating with the appliance in. Yeah. Let me tell you, with a bonded hyrax, do they have much choice to eat with the appliance in or not? They either starve or they eat with the appliance in. You got it, right? So this is where I'm coming from a sensibility point of view, but I'm not here telling you, that's bullshit, those removables don't work. They do work. I mean, I used them for many years, but I also had a lot of frustration over many years. And I'm trying to guide you into a predictable treatment plan. I want you guys to be successful, you know. After all this money you're investing in time, you should be doing, 200 cases a year. I mean, she does, so I don't see why you guys couldn't. Because every man and his dog in the UK needs orthodontics, so yes or no, right? It's just a case of convincing them that the orthodontics you do is a slightly different level, right? You're not competing against the local consultant who would agree with that, because you're doing something totally different. And this is where I think the niche market is there for you. So mid-phase deficient, end of phase 1, breathing technique. The tongue is the retainer, right? So I'm using this case as a guide, and I want you to read this article. Journal of Pediatric Dentistry, changes this is by Ramirez, changes in the upper arch are maintained with the position of the tongue and a trainer, right? So T4K is fine if it's a class 2, but IC3 is fine if it's a class 3. Bottom line is, and this is from McEwen, over the past 20 years, I've come to understand and recognise the health issues related to poorly directed growth and development, importance of face, etc., importance of horizontal growth. But bottom line is, the single most important thing you can do to a child's health is to establish nasal breathing. I can't push that line any further. If I had my time again and like I was still in school, like as in high school, I would have definitely done medicine and become an ear, nose and throat doctor, right? Knowing how important that is. To me, early treatment orthodontics is all about that. All about that. So you've got to be on the lookout for airway. Your case yesterday with the high palate, straight away I'm assuming there's some airway concerns. So everyone can expand with or without a removable, but it's maintaining that expansion. What maintains your upper arch form? The tongue. What maintains the tongue position? The nasal breathing. Does that kind of make sense? So this is one of those courses where I push myofunctional as much as orthopedics, as much as orthodontics, because without the 3, you're not getting the ideal results. And again, just showing you, rather than the BioBlock, and then, you know, because if you have a BioBlock or a short sagittal with a lot of crowding, like that girl I showed you that we weighted a bit and her teeth were everywhere, that's going to be a tough case than to take out your removable and go 2x4 without anything but a round wire. And then during that couple of months of round wire, you're going to lose your expansion. Yeah. So here's the deal. Bonded Hyrax with 2x4. When you get into the 1825, that's when I'm taking out my bonded Hyrax, and I can stay in the 1825 to bond my 6s, because at the end of the day, here's the 6, here's the 2-to-2. Even if the 6 is a bit rotated, that 1825 fits in beautifully. That's what I use to maintain my expansion in these cases.